Hypothermia drives potassium into the cell. So hypothermia can cause hypokalemia because it drives potassium in cells, right? Now, in hypothermic patient who are not responding to resuscitation, they may be hyperkalemic. Due to this hyperkalemia, because of the hyperkalemia, they are not responding to the resuscitative effect of hypokalemia, in hypothermia. Hypothermia drives potassium into the cell. It should cause hypokalemia. But in hypothermic patient, on the contrary, just opposite to this, in hypothermic patient who are unresponsive to resuscitation, they have marked hyperkalemia, right? This is because of the tissue necrosis, the irreversible changes in the tissue which has happened. So hypothermic patient with marked hyperkalemia, they will not respond to resuscitation. That's one of the signs to leave the resuscitation. In hypothermia, routinely hypokalemia should be there. In hypothermia, there should be hypokalemia. If in hypothermic patient, hyperkalemia is happening, that's a sign that your resuscitation will not be successful. Okay, then loss of potassium is the other group of cause causing hypokalemia. The loss can happen in urine, after the use of diuretics, after dialysis, after peritoneal dialysis, after hemodialysis, right? So, loss of potassium, right? Now, number one, increased loss from gastrointestinal tract. So this how the loss will happen? By vomiting. Let's say vomiting is happening in the patient, diarrhea is happening in the patient, right? Your, let's say, the tube drainage, the nasogastric tube drainage, the nasogastric tube drainage is happening, or laxative abuse, increased prescription of laxative, all this would cause hypokalemia. Now, one thing, just a clinical point I want to say, that in upper GI losses, the risk of hypokalemia is less. The risk of hypokalemia is less. Why? Because in upper GI secretions, potassium is less. So, vomiting would less cause hypokalemia. But lower GI losses, as in diarrhea, the risk of hypokalemia is more. Risk of hypokalemia is more because lower GI secretions have more of potassium. Okay. Then increased urinary loss. As in case of increased mineralocorticoids activity, increased distal delivery of sodium and the fluid, and in polyuria. So increased urinary loss will happen in number one, increased mineralocorticoid activity, then increased distal delivery of sodium and fluid, water, increased distal delivery of sodium and water, and in case of polyuria. So in all these cases, there would be increased risk of hypokalemia. Then what are the symptoms of hypokalemia? Well, symptoms of hypokalemia and hypokalemia more or less same. Here also we have muscle weakness. So let us talk about clinical features, signs and symptoms. Okay. So muscle weakness. This will not manifest until and unless the serum potassium is less than 2.5 milliequivalent per liter. And the pattern of the weakness is more or less same as in hypokalemia. First the lower limb, then the trunk, and then the upper limb. So pattern of weakness is like first lower limbs, followed by trunk, followed by upper limbs, right? This is the pattern of ascending kind of weakness. with hypokalemia, right? So we need to keep in mind. And apart from this, patient can have muscle cramp, rhabdomyolysis, myoglobinuria in hypokalemia. So muscle cramps, then rhabdomyolysis and myoglobinuria can also happen. Apart from other muscle weakness manifestation, respiratory muscle weakness, respiratory failure, and even death can happen in the patient. GI muscle involvement can cause GI ileus, then distension, anorexia, right? In ICU patient, hypokalemia would not let the patient accept the let's say feeding, the enteral feeding of the patient. We need to correct the hypokalemia. So in case of other muscle manifestation, right, respiratory muscle involvement, respiratory muscle weakness can cause respiratory failure and death in the patient. Then GI muscle involvement, right? It can cause ileus, right? Ileus, distension, anorexia, nausea and vomiting, right? Now remember, in colonic pseudo obstruction, I mean, one condition I want to mention it here, just note one condition, that is Ogilvie syndrome. Ogilvie syndrome. Now this causes pseudo obstruction, colonic pseudo obstruction, and in this what is happening? The potassium is getting lost. So increased potassium level decreases because of loss of potassium in the urine, right? So this is Ogilvie syndrome, which causes pseudo obstruction. In this hypokalemia causes colonic pseudo obstruction. Okay. Then other manifestation apart from the muscle weakness is on cardiac arrhythmia and ECG abnormalities. So cardiac arrhythmia and ECG abnormality, every kind of conduction delays and arrhythmia can happen. So patient can have premature atrial complexes, premature ventricular complexes, the asystole can have VT, VF, any kind of arrhythmias can be seen in the patient. So patient can have premature atrial complex, patient can have premature ventricular complex, sinus bradycardia, right? Patient can have AV block, various level of AV conduction block, atrial fibrillation, ventricular tachycardia, all kind of conduction and rhythm disorder. What are the typical ECG changes? ECG changes seen in hypokalemia, right? In hypokalemia, we have ST depression, right? We have decreased T wave amplitude, and U waves appear. You can see this, U waves appear. So U wave appears and QT time can be prolonged. So prolong QT interval, right? QT interval. So what all I said, the ECG change. In hypokalemia, ECG changes in hypokalemia. So this is important. We need to keep it in mind. Number one, what will happen? ST depression. ST segment will get depressed. Decreased T wave amplitude. Then U wave would appear. U wave will become prominent, and QT prolongation, right? So all these are the ECG changes in the hypokalemia. Okay. Now other manifestation of hypokalemia would be on kidney. persistent hypokalemia can cause kidney abnormalities. So prolonged hypokalemia can cause multiple structural and functional changes in kidney. This could be impaired concentrating ability of the kidney, increased ammonia production, increased bicarbonate reabsorption, altered sodium reabsorption, hypokalemic nephropathy, then your elevation in the blood pressure and decreased phosphate reabsorption, right? Now, these kidney abnormalities are more, they could be, they could, in case of already renal impairment, this can get exaggerated in persistent or prolonged hypokalemia. Now, hypokalemia can cause glucose intolerance. Hypokalemia reduces the insulin secretions also. So, hypokalemia reduces insulin secretion, which play an important role in your thiazide associated diabetes. So when we are giving a low dose thiazide diuretic to a patient for a prolonged time, it can cause hypokalemia and this can cause glucose intolerance, because the potassium is responsible for the insulin secretion. So what would happen? Insulin secretion will decrease, insulin deficiency will happen. So it can cause glucose intolerance as well. Okay, so these are the manifestation of your hypokalemia. Now let us talk about management of hypokalemia. So once we have discussed manifestation, let us talk about management, and the mainstay of the management is potassium supplement, right? So remember, hypokalemia management or treatment, what is the goal? The goal is to prevent life-threatening complication, correct the potassium depletion, and identify the cause and treat the cause. So the goals of the treatment are prevent life-threatening complication, replace potassium, diagnose cause and correct it, right? Urgency of the management depends upon the serum potassium level. So whether it is urgent, right, it depends upon the serum potassium level, right? Now, a lot of patients who are more at the risk of arrhythmia caused by potassium. So in those, the hypokalemia should be aggressively treated. So risk of arrhythmia in decreased potassium level is seen mostly in old patients, patient with organic heart disease, patient on digoxin, right, and patient on any antiarrhythmic therapy. So we have to be even more careful in these patients. The mainstay, as I said, of the management is potassium. So potassium supplement is the mainstay of the management. Supplement is mainstay of the therapy, right? Now, potassium deficit varies with severity of potassium, overall potassium concentration of the body. So just one word about it, that potassium deficit varies with severity of potassium concentration. So how low the potassium, the clinical sign and symptom would vary accordingly and the urgency would vary accordingly. For 0.27 milliequivalent per liter fall in serum potassium, we have 100 milliequivalent of decrease in body potassium store. Okay, so for 0.27 milliequivalent, 100 milliequivalent. So if I just round it to 1 milliequivalent per liter of serum potassium fall, we have 200 to 400 milliequivalent of potassium deficiency in the body, right? So this is what we have to keep it in mind. So along with the mainstay of potassium supplement in the treatment, potassium sparing diuretic is the another treatment modality which we can use in special patient. Now there are two classes of potassium sparing diuretic. The blockers of cortical collecting tubule, that is two places where potassium is secreted in the principal cell. One is cortical collecting tubule. So here the potassium sparing diuretic block it, amiloride and triamterene here, and aldosterone antagonist, right, which would inhibit the secretion of the potassium. Potassium secretion depends upon the aldosterone presence. Aldosterone antagonists like spironolactone or eplerenone, they can also be used to increase the serum potassium level by decreasing its excretion into the urine. Okay, so these drugs are mostly used when increased loss of potassium is happening in the urine. So increased renal potassium wasting is happening. So they are only considered in that case, right? If huge urinary loss of potassium is happening. Okay, so let's talk about mild to moderate hypokalemia. What we do in mild to moderate? Mild to moderate means normal potassium level is your 3.5 to 2.5. So mild to moderate, the serum potassium level would be 3 to 3.4 milliequivalent per liter. So we call it mild. So normally patient will not have any symptoms. So generally no symptoms, right, in this case, except in cardiac patient or cirrhotic patient. The symptoms would be there because potassium hypokalemia would cause, I talked about the effect on the kidney. It would increased ammonia production. So in cirrhotic patient, it can cause encephalopathy. So only in cirrhotic patient and in cardiac patient, we need the manifestations can be there. So otherwise no symptoms except in cardiac patient or in patient with liver cirrhosis, cirrhotic patient. Okay. So if the patient is having hypokalemia, we need to give potassium supplement. Now there are various preparation available depending upon whether alkalosis is associated or acidosis is associated with hypokalemia. We choose the supplement. So if hypokalemia with alkalosis, then we give KCl, right, potassium chloride preparation. And if it is with acidosis, we give potassium bicarbonate preparation. So if it is with acidosis, then we give potassium bicarbonate preparation, right? Okay, how do we supplement it? 10 to 20 milliequivalent of potassium 2 to 3 times per day in case of mild to moderate hypokalemia, right? That is, we will give 20 to 80 milliequivalents per day, right? We don't need more than that. This is mild to moderate hypokalemia, okay? But in case of severe or symptomatic hypokalemia, the supplement has to be faster and more has to be given over the day. So potassium must be given rapidly, And remember guys, whenever you have to give potassium rapidly, then central line is always preferred. Potassium extravasation in the muscle tissues can cause necrosis. So potassium must be given rapidly. Here the level is between 2.5 to 3 milliequivalent per liter, or patient is having symptoms which we have already discussed: muscle weakness, arrhythmia, conduction block, etc. So in this we will give 10 to 20 milliequivalent per hour of potassium through central vein, preferably. We can give by peripheral vein also, but diluted fluid concentration should be used. I'll talk about that. So mainly through central vein. And when we are giving it at such a high rate, we need to have a careful monitoring, right? Careful monitoring with ECG, continuous ECG monitoring, serum potassium level, and symptoms. We have to look for the improvement of the symptoms, right? So monitoring should be done. So how do we prepare the potassium solution to give it to the patient? Now potassium can be given IV through peripheral or central vein. Preferably if you have central vein, we give it by central vein. Now if I have to give it, let's say with a huge amount of fluid I can give, then 1 liter sized big container of non-dextrose fluid, we can mix 60 milliequivalents of potassium. This dilution we can prepare in normal patients. Now let us talk about individually about peripheral and the central line. So for a small volume, if I'm not using 1 liter bag, small volume, 100 to 200 milliliter of water is through the peripheral vein with 10 milliequivalent of potassium. 10 milliequivalent of potassium, right? 100 to 200 ml of we can use non-dextrose containing fluid in which 10 milliequivalent through peripheral vein. So this dilution should be made in for peripheral vein. In let's say 100 ml of let's say non-dextrose containing fluid through large central vein, we can mix 40 milliequivalents of potassium if we don't want to give a lot of fluid to the patient, right? IV potassium is most often infused through peripheral vein at the concentration in saline 20 to 60 milliequivalents per liter in non-dextrose containing saline solution, right? In non-dextrose saline containing saline solution. Okay, so 20 to 60 milliequivalents per liter. This should be for the peripheral vein infusion concentration. Now, use of infusion pump is preferred if we are giving a rapid potassium administration, or if we are giving more than 4 milliequivalents of potassium more than 4 milliequivalents in, let's say, 2 hours. If desired rate of potassium administration is more than 10 milliequivalent per hour, then we need to give it through the infusion pump, right? So very fast potassium correction should be avoided. So let me just simplify it. For a peripheral line, 1000 ml fluid, in that 60 milliequivalents of potassium should be mixed. This dilution is preferred, right? We can give 10 milliequivalents of potassium, 10 to 20 milliequivalents in 100 to 200 ml of through peripheral line, but through central line I can give a very high concentration up to 40 milliequivalents per 100 ml. So 40 milliequivalents per 100 ml can be given through central line. Okay, so I can give in a higher concentration, but this is a high hyperosmolar concentration. It can cause tissue necrosis if extravasated in the tissue. So for peripheral line, always a dilute concentration should be prepared, right? Infusion pump should be used if you are giving it a faster rate and if you are giving more potassium. More than 40 milliequivalents if you are giving in a day, use an infusion pump. If you are giving at the rate 10 milliequivalent per hour, use an infusion pump, and always use central line, right? In patient with severe hypokalemia, large central vein is preferred if this access is available, right? So as soon as is possible in severe hypokalemia, put a central line in the patient. Okay. Monitoring, as I said, we go for the ECG, continuous ECG monitoring, potassium, and we see the symptoms of the patient. Serum potassium level should be done 1 hourly in case of severe hypokalemia. Got it? Okay. Adverse effect of IV potassium. Now, pain and phlebitis if we are giving at more than 10 milliequivalents per hour, right? So, pain if we are giving through peripheral line, pain and phlebitis if we are giving at more than 10 milliequivalent per hour rate, right? If you are giving more than 40 to 60 milliequivalent per day, the risk of hyperkalemia is there. So you need careful monitoring. So we have to be very careful when we are giving potassium supplement. Okay. So this is all about management of hypokalemia. Thank you.